As the next group is coming up, I just want to mention our sponsors for this 2-hour session, and that is best introduced by asking by a show of hands those present, did you know Vernal Johnson? Raise your hand. So a number of us. So Vernal Johnson, of course, died in his 100th year. Shortly before his death, he caught 15 rainbows, and he also went skiing that year. So may we all be able to do so well. So the Steve Johnson, Joyce Johnson, and Val Johnson family, in memory of their dad, Vernal Johnson, supported this along with the Utah Medical Association Foundation. So Rhett Smith was born in the small southern Utah town of Beaver, Utah. We've heard that before. Graduated magna cum laude with a Bachelor of Science from Southern Utah University and earned his MD from University of Utah, not from a Caribbean institution as has sometimes been suggested. He is currently chief resident at McKay, and following residency he'll join his dad and his brother Lance, a former graduate of our program, down in the Beaver Medical Clinic and work at the Beaver Valley Hospital. Rhett is married to Melissa, who also shares Beaver as her hometown, father of 3 children, and outside of work and family he enjoys hunting, which includes chasing coyotes, fishing, football, basketball, baseball, golf, hiking, working outdoors, and playing on my softball team. Dawn Pruett. Dawn Pruett was born and raised in Connecticut, where they also have colleges, and she attended Wagner College and then Boston University for undergraduate and graduate, earning a bachelor's and then a master's in chemistry. She worked for one of the evil institutions, or at least it seems like that so much anymore. She worked for Pfizer and then started medical school and went to the Oregon Health Science University, graduating in 2013. She too hopes to graduate next month, depending on her behavior here in the next few minutes, and has a strong interest in maternity care and will be doing a fellowship in maternal and child health at the University of Rochester in New York. She also is married, and we've enjoyed her and her husband and her family as well. And finally, Dr. Madsen, whose name has already come up. Dr. Madsen was one of the poster winners last year and one of the poster winners this year. So we appreciate his interest in research and participating in Ogden Surgical Medical. He studied biomedical engineering at University of Utah, where he researched risks associated with stroke in patients with left ventricular assist devices. Attended medical school at the Cleveland Clinic, Lerner College of Medicine, where he was awarded the Fischleiter Leadership Award. He also earned a master's degree in clinical research for his thesis on 3D printed surgical tools for the patient-specific correction of bunions. He also worked on the development of multidisciplinary concussion pathway and the development of the C3 application for concussion management. He is also one of our chief residents currently, and assuming we allow him to graduate, he plans to attend a fellowship in primary sports medicine in California. He is planning a future career as a family medicine physician and sports medicine and hopes to be involved in an academic environment. He spends a lot of time with his children and his wife, Jennifer. Thank you very much, and we'll turn the time over to Rhett.
So I think they stuck me in the middle because mine is somewhat less academic to break it up, so I hope you still will enjoy it. I'm going to talk a little bit about the electronic health record today. I have no disclosures. I want to start out by telling you a story that I read in JAMA. The story is of a young man who desires to be a doctor, goes to medical school at a well-known university, does very well, and decides that he would like to pursue pediatrics. He does well with children, he enjoys pediatrics and would like to serve that population. He also decides that he's going to use the military to help pay his loans, and so he becomes through the Army, a military paid pediatric resident. and is very well respected and very well liked. He, by all of his colleagues' reports, is very charismatic, very enjoyable to be around both as a doctor and as a colleague, and is very good with his patients per report. He actually is one of the chief residents at his residency and actually has a few kids of his own during his residency, and so very much loves children and loves his job. However, one day, one of his patients, well-meaning, one of his pediatric patients, brought him a picture, as they so often do in pediatrics, and he was very flattered by the picture. But when he looked at the picture, he saw something that was very disturbing to him. And this is the picture that he was given. And you can see, I'm going to use the pointer on this screen, you can see here the patient sitting on the exam table, and she is, underneath her there's some books and some toys, and then, well, my pointer's not working. But next to her, you can also see her mother and her younger sister and a baby in one of their arms. But if you look under the red arrow, you see the physician who, with his back turned, is documenting on the computer and not really engaged in the visit. And he was being a very charismatic and people person, he was very disturbed by that picture, that was the perception that his pediatric patient had of him. And again, this is from JAMA 2012. He was very surprised by this, and he said, when he saw it, he said, and if you look in the underlined part, the economic stimulus bill has directed $20 billion to healthcare information technology, largely funding electronic medical record incentives. I wonder how much this technology will really cost. He was really bothered by the fact that he was perceived in that way by his patients. Led me to question in my own mind, what kind of doctor do I want to be? When I started medical school, when I was trying to get into medical school, I wanted to help people, to be a good person. Did I picture myself as this type of doctor you see on the screen, or as this type of doctor? And I challenge you to think about that in your own mind. My journey on this topic and why I decided to talk about this topic started with Dr. Robert Mosinger Jr., who's a general surgeon at McCady Hospital and very well-respected man who has taught residents for years and also teaches a number of other students, PA and medical students, and is a very good surgeon, a very good teacher. Because of his years and years of teaching, he's compiled a number of articles, mostly primary literature articles, that he has shared with the residents as they come and rotate with him. He has a standard stack that he hands you. And most of them are about gallbladder, cholecystectomy, appendectomy, hemorrhoids, whatever, hernias. And when I rotated with him, which was about a year ago, I, trying to be a good student, read all of the articles. And as I read through, I again read gallbladder, appendix, and then in the middle, there was another article called The Electronic Health Record, Are We the Tools of Our Tools by Ober, which was published in 2015 in the Pharaohs Journal. And it really struck me that there was this non-academic article in his stack to give to the residents. And around the same time that I read this article, we at the Porter Family Medicine Residency Clinic started doing something called CBT Clinic in conjunction with Dr. Blaisdell, who's our behavioral health coordinator. Many of you who are in psychiatry or primary care know what CBT is, which is cognitive behavioral therapy. It's not something that doctors traditionally do much of, but in an attempt to help us help our patients who have anxiety and depression, he has been teaching us to do this on a very limited and small number basis while videotaping us. And so the residents will see a patient with depression or anxiety, do some counseling with them, cognitive behavioral therapy, and then come back to report to him, and he's watched on videotape what we've done, and he gives us suggestions. And around the same time I read the article, that was starting, and I noticed that when I watched them that there were certain residents who spent their entire visit face-to-face, body language directed towards the patient, very engaged, and there were others who spent a lot of time on the computer. Around that same time also was the rollout of our new electronic health record, iCentra, which is by Cerner for Intermountain, which has been a great EMR, electronic health record, by the way. But that was a time when we were changing our habits. When I first read the article that I mentioned previously, one of the things that struck me was this quote: "As we have seen with new drugs and new devices, the most important unforeseen problems frequently come to light during post-marketing surveillance." And you can think of drugs and medical devices that have come and gone in your practice that have been great initially, and then a couple years later found out there were problems. Fen-Phen, for example, was one. Was great initially, and then there were some issues. How about Vioxx, a great anti-inflammatory that later was found to be somewhat harmful? Is there a chance that the electronic health record is that way? It's certainly beneficial and helpful in a lot of ways, but are there things we're doing with the electronic health record that are maybe harmful to our patients? This is also a quote from the article, which I won't read, but essentially the take-home was that as new institutions institute new electronic health records, there are many problems, including billing problems through the electronic health record, provider frustration, patient frustration, and we saw some of that with our rollout of our electronic health record. As good as it was and as good as it is, we saw many frustrations during the initial rollout. And these are just, again, some of the problems that we see. Billing problems, providers are frustrated, there's delays in patient care sometimes. It's actually well documented that there's barriers to medical education with the advent of electronic health records as compared to the old paper chart days. Templates are sometimes a problem because they are too much of a cookie cutter, as well as copy and pasting notes sometimes creates inaccuracy in the record. And then readable notes. A lot of our EHRs now are designed for data collection and billing, but when you look at the note, it's kind of hard to clinically know what's going on in some of the electronic health records. And then medical errors are a problem. But none of those are the primary problem, in my opinion. The biggest problem is where we started, and that is, and this quote sums it up, what had always been considered to be the most immutable aspect of medicine was and is under assault. The patient was no longer the most important thing in the examining room. The machine, rather than the patient, had become the center of the doctor's focus. All of us are guilty to that in one degree or another, but I believe that is one of the problems we face with our electronic health record, is that we have to divorce ourselves from the computer in the exam room sometimes to talk with the patient. The resident who we mentioned earlier said he still can't seem to get past the urge to just toss the computer aside and actually talk to people when I see them. And many of us have felt this frustration. Sometimes the computer just becomes too much and you want to get rid of it in some way or another. But is EHR all bad? Obviously not. And it's not going away either. It's government mandated, and there are a lot of benefits to it, from data collection to electronic prescribing to interfacing between EHRs for better patient care. There are benefits to it. When I began looking into this, I came across the study, and I know this is a busy slide, but focus yourself to the two red arrows. The left arrow shows the amount of time in a study that was done that a doctor spends looking at a patient, which is 46%, versus looking at the computer, which was 30%. So about a third of the visit was spent, and this was a study that was done in 2014. When I saw that, I thought that maybe I could do a study of my own and As I mentioned before, we were doing a CBT clinic that was already being videotaped, so I thought that was a perfect opportunity for us to study how much time the residents spend looking at the patient and how much time they spend looking at the computer. And Dr. Blaisdell collected most of that data as he watched the residents do their CBT. The three things we looked at was how much time does the doctor look at the patient, how much time does the doctor look at technology, and then something else other. What we found in comparison to that 2014 study that I just mentioned is that the McKay residents, and let me mention it's not just the residents, I collected some of this data from the hospitalists that I spent time with as well as some of the specialists that I rotated with. But what we found is that the residents and those that I studied spent more time looking at the patient and less time looking at the computer than had been reported in the literature, at least by that one study. There are some limitations to that, of course, because the residents may not have been under the same time constraints as a private practice doctor, and they knew they were being videotaped, so a little different. And looking at the remainder of the data that's out there about this, in 2006, there's a cross-sectional study that essentially the conclusion of the study was that over time, there's a shift towards a more business-like, task-oriented communication pattern reflecting an emphasis on evidence-based medicine and protocolized care, and that the computer could play a role in that, as well as other studies that were done in 2010 that demonstrated, this was a study that was done over about 10 years that demonstrated that essentially the computer played a negative role in the exam room by drawing the doctor's patient attention away from the patient. And also the doctor gave less advice to the patient and spent more time on the EHR. So what conclusions can we make from both my study and looking at what's been done? First of all, the electronic health record is here to stay. Again, like I mentioned, it's not going away. And it's a good thing in a lot of ways. I'm not trying to portray it as a completely negative thing. It's a very good thing in a lot of ways if it's used correctly. And now, at this time, it's relatively new as far as medicine goes. Medicine has been around for quite some time, and the use of computers to document patient notes is relatively new. And now is the time to make any changes regarding that behavior and using the computers as we're forming new habits. And then, if I may, and you can tell from my talk what my opinion is already, but let me share with you my opinion, which is the computer must become our servant, not our master. The encounter with the patient belongs to the patient and not the business office, and that the patient deserves our undivided attention, not the computer. And I know that our patients will appreciate that if we do that. Well, how do we do that? In the setting of a busy practice and trying to keep up, because that's what most of our concerns are. One way is by using scribes. There's a lot of data that supports the use of scribes, both financially helpful. They actually make doctors money in the studies that have been done, as well as they improve the quality of the documentation as opposed to the doctor doing the documentation because they're rushing to do it. Perhaps a culture change needs to take place when we refocus our attention on the patient. Perhaps we document post-encounter only. This is what I do. I go in the room, I see the patient. It's much quicker when I'm not trying to take down their history on the computer. I can just talk to them quickly, examine them quickly, and we're done. And then after the visit, I spend 2 to 3 minutes on the Dragon Dictate software dictating my visit. It takes about 2.5 minutes, but I save 2.5 minutes in the visit. Voice recognition software like Dragon does play a role, or can play a role. And then our electronic health record could be improved, simplified, and be more user-friendly to help with this problem. And I'd like to acknowledge Dr. Blaisdell for his help with collecting the data for this, and thank you.
I'm not that tall. Thank you all for coming out and supporting us and hearing our talks today. It's nice to see so many familiar faces. As Dr. Campbell mentioned, I am next year going to do a maternal child health fellowship focusing on obstetrics, and so that's a big interest in mine. And I'm talking today about a study that I really started in my first year of residency that involves looking at our residency training program in C-sections. And nothing to disclose. So first, some background. So nationally, about 4,000 family medicine trained physicians perform C-sections as a primary surgeon all across the country, primarily in rural areas. And thinking about residency training, just over half of family medicine residencies provide training in C-sections. And so to some of you in the audience, this may sound crazy or be surprising. Is this even allowed? But it is. So this is a statement from the American Academy of Family Physicians and the American College of Obstetricians and Gynecologists, a joint statement. And I'll read it through, but focus on the highlighted part. So they say that the assignment of hospital privileges should be granted on the basis of training, experience, and demonstrated current competence. Competence is a big word. All physicians should be held to the same standards for granting of privileges, regardless of specialty, in order to assure the provision of high-quality patient care. And I think a big reason for this is because there's a need, especially in rural areas. So many women currently in rural areas need to travel long distances in order to deliver their babies. So they get their prenatal care locally, but when it's time to deliver, or maybe weeks before it's time to deliver, they have to travel to the big city. We know that communities without obstetrical care have worse perinatal outcomes, and that can be expected. We also know that sometimes a C-section is not anticipated, and sometimes it happens fast, and the indications can arise suddenly or emergently. And there's been multiple studies that have demonstrated that there's no worse outcomes between obstetricians and family medicine physicians who provide cesarean delivery and cesarean care in rural areas. So the outcomes are no different. And so looking at our residency at McCady Hospital, about 20% of residents in the last 10 to 15 years have gone on to obtain primary cesarean section privileges. A lot of them are here in the room. Just looking at Utah, we have about 12 different cities where McCady residents are performing primary C-sections. And none of these residents actually did a fellowship. And outside of Utah, there's also graduates as well in Oregon and Idaho, Missouri. So our residency provides the training, but sometimes it can be difficult. There's some challenges. Number one, our training is only 3 years, so that's not a lot of time to develop those skills. We're learning a lot of other things as well. There's a limited number of patients that we are involved in. So we have our prenatal patients that we take care of at Midtown Clinic, and we do their deliveries. Greg talked a little bit about that. And then we are involved in some of our attendings deliveries as well. Prior to a couple years ago, the privileging, or when it was time for a resident to do a primary C-section, was really sort of undetermined, and the training that residents got was very serendipitous. So it was very dependent on relationships and how many you've done with a particular attending, and if they liked you, or if all kinds of different things. So, and I think a lot of residents feel like we don't get a lot of feedback in terms of our surgical skills. And so these were some of the challenges that I tried to address in a curriculum that I developed for our residency, which I'll talk a little bit about later. But it brings us back to the word competence. So we want to be competent, or we want to achieve competence when we graduate in order to gain privileges at the place that we're going. But what does competence mean? And so here are some thoughts. Perhaps it means a low rate of complications, so that would be good. Minimal blood loss in the procedure. Maybe it means doing the procedure quickly and efficiently. Or maybe it means that someone more experienced watches us do it and says, yes, you are good. They give us their blessing. But what I chose to look at in terms of our residents was the speed of the procedure. So looking at whether our residents have achieved competence in terms of operative times. And so what I did was reviewed procedure logs from a few of the residents who have graduated recently, looking at their cases that they were the primary surgeon from the first one to however many they did, and looking particularly at the operative times for each case. And why did I choose operative times? Number one, it was probably an easy and objective measurement, but I think it's also important in other ways. So in the operating room, time is money. So the longer we spend in the operating room, the more it costs the patient, the more it costs the hospital, the more we're taking resources from the labor and delivery floor. So it is actually an important thing to look at for us in our training. And then also, there are several papers that describe, at least for OB residents, that the number of cases that they performed, as they perform more and more cases, their operative times go down. And that this actually correlates with other measures of competence as well, such as blood loss and complications. They noted that generally the learning curve, that they called it, flattens around 40 cases for OB residents. And so this chart here, I don't know where to point, the x-axis is grouped in fives, so from the resident's first case through fifth case is sort of the first one. So it's the mean operative time of those first 5 cases. The second point is 6 through 10, and so on. And so you can see that the more cases they did, the operative times decreased. So this was the graph that I hope to replicate. So here we are. I would like to say that this means that our residents were competent just from the very beginning, but I don't know that that's what it meant. But so looking at our residents, again, the 6 residents that I looked at, as cases went on, our learning curve is actually fairly flat. And I think that there's a few reasons for that, which I'll talk about here. And so I think the way our residency works, we have a lot of what I call graduated autonomy, in that our first case as a primary surgeon, we are on the other side of the operating table, but we may not actually be as much in charge as perhaps our 30th case or something like that. And so the OB attending that we're working with may still be sort of running the show, and in terms of time, operative time, may make us a little bit faster, whereas over time, between our first case and, let's say, 30th case, we become more and more in control in managing the case. I think another big limitation to my study is that I was not really able to account for different attendings having different baseline operative times, and it's very different. So some attendings are very fast, some attendings are slower. And I think the other thing that was difficult to sort of control for, although we tried, was various situations. So repeats versus a primary section, tubules or not, doing suture skin closure versus staples. All of those things may add time as well. And then I wasn't able to measure complications. So it ended up being about 180 cases or so, I think. And so it was difficult to look at the complication rate in that few number of cases, but that certainly is, I think, a big component of competence as well. Another thing that I wanted to look at was whether our residency training really slowed down the flow of the OR. So again, thinking about operative times, are we taking too much time? Are we taking up resources and that kind of thing? And that, I think, was an important thing to look at. I think our residency commits to cesarean section training, but at what expense? And so what I did was sort of look at about 30 different attendings and their operative times, their mean operative times, and then plug the resident number in there. And in fact, we're not the slowest, and we're probably about, in the about 75% over in terms of the length, but we're certainly not the slowest. And I think that that's a fair thing, and so an important thing to think about. So because our opportunities are fairly limited as residents in terms of gaining numbers and opportunities for learning, I wanted to develop an intentional curriculum and process to try to reduce and improve the learning curve, meaning to make us faster and better as soon as possible. And I won't go into great detail in terms of the curriculum, but it has a few different components. One is that it thinks about this graduated autonomy in terms of technical skills, knowledge, and experience, and giving residents more and more privileges based on how they're doing. I designed an evaluation that residents can give to attending physicians as they're right after a case, so they can get some prompt feedback and sort of allow residents to talk about how they did and hopefully improve that way. And then the program also, which is a new thing, establishes a mentor for the resident. So an OB attending that can talk about how they're doing and what their future plans are and what they need to focus on. And then a component also emphasizes evidence-based surgical techniques. So residents will actually give a presentation about a surgical topic as part of the process to achieve privileging as residents to do primary C-sections. In the future, it'd be great to study the residents that have gone through this curriculum and see if their operative times are faster, if we really did help to improve and reduce that learning curve. And then also I think it's important to continue to develop methods of evaluation. It's really hard to determine competence for something as complex as a surgical procedure, but I think that that we should strive to do that. So in summary, family physicians have an important role, especially in rural communities, for providing comprehensive maternity care, including cesarean sections, and I think that our residency does a really good job at helping to provide that resource. Achieving competence in C-sections can be challenging, including in our residency, but hopefully the program that I designed will help with that, and that hopefully residents after me as well will continue this effort to improve our training. And that is all. Thanks.
All right. Well, everybody, thank you for sticking around and hearing my talk. I'm really excited, and I know some of you are here for the lunch, and that's okay. Hopefully you'll get something out of this anyway. And if you're out in the hallway, feel welcome to come in, and the lunch is going to come in just a little bit. So we actually had a really good talk a few days ago about genetics and the sports gene, and we had the author of the sports gene come and speak to us. But today we're going to spin that a little bit and talk about how, it's not just our genes that affect our performance, but it's also the environment that we're in. We're fortunate enough here to have an amazing venue for that in the Ogden Marathon, which, if you aren't aware yet, is actually happening tomorrow. So if just a raise a hand, anybody here actually participating or going to visit or watch the Ogden Marathon tomorrow? Raise your hand. Okay, I was hoping for a few more, but that's good. That's good. That's a good start. Hopefully I can inspire you here a little bit. So first off, I just want to mention that I also do not have any financial or political disclosures to make. I did this out of curiosity. I did this because I really wanted to know the answer to some questions about how the environment affects us. I've been a physician with the Ogden Marathon since 2014 and have loved every minute of it. As mentioned, I'm actually going to be moving here in a month to Southern California to be a sports fellow at UCLA, but I'm definitely going to miss this area. One of the reasons is because we really do have a gem here in the Ogden Marathon. I think people underestimate, or if you haven't heard as much about it, it is one of the finest marathons in the country. 2010, Runner's World, a prominent running magazine, named it one of the top 10 marathons in the world. And it's consistently been named one of the best marathons for beginning runners because of its nice scenery, nice gradual course, and great weather. So every year we have this marathon here with 3,500 marathoners and 4,500 half marathoners. And it runs through our area here, starting up above Eden and Huntsville and running down through past Pineview, through the Ogden Canyon, and into Ogden itself, finishing at 25th Street. So it kind of runs through the whole area. And you know, the nice thing about going from up in the mountains to down here is it's a nice downhill run. So if you're thinking about running a marathon, you should definitely consider this one. Probably not tomorrow, though. That was not a very much time to train. So with this wonderful marathon, I thought it would be interesting to know the different hazards that these runners experience over the course of 26.2 miles. And a lot of it has been documented, but some of it has not, and we're going to address some of that here. Talking initially about the heat risk that's been documented in endurance athletes, but also the risk that happens here in Ogden. So the data that I'll be presenting is local data from our own marathon. So it's been well documented that the endurance athlete is exposed to some extreme environments, and even mildly elevated temperatures can be dangerous. So to the point that there are recommendations from several societies, including the American College of Sports Medicine, about altering or even ceasing of activities for endurance athletes based upon the temperature, because there is definitely a direct correlation between the temperature and the number of injuries and the severity of injuries. So I don't know if any of you know a runner. Runners are a special breed of people who are willing to go through a lot of pain and suffering to achieve their goals. And so oftentimes, this is important because oftentimes as physicians, we actually kind of have to pull them back. And it's not unheard of for marathons to be canceled, rerouted, or postponed because of the temperature. And there are actually quite a few recommendations about that, which I wish I had time to go over today. But I do want to mention that our marathon is no exception to this. Over the last few years, the number of injuries experienced at the marathon, and this is all injuries, correlates quite well with the temperature, ambient temperature that day. And here is measured the maximum temperature during the day, not necessarily the temperature the runners were running in throughout the course. We were missing, unfortunately, data from 2011, but you can see how closely the temperature and the injuries seem to run, except for the last 2 years. And if anybody ran in the marathon last year, you'll remember that it was amazingly cold and amazingly wet. So most of those injuries were actually hypothermia-related injuries rather than heat-related injuries. And so what I did is I pulled out just the heat-related injuries, and the diagnoses we used are on the side there. But you can see that we do have a very good correlation between the injuries and the temperature. And these are just heat-related injuries, except for 2014. And I've racked my brain about what could have caused this in 2014. And there are several things that could be, but I'm pretty sure the reason is there were less injuries because I was the medical director that year. And so maybe they'll ask me to come back next time. So we looked at the number of the type of injuries, the number of injuries that happen related to the heat. But what about just athlete performance? Will an athlete run faster or slower because of the ambient temperature or the air quality? And I especially started thinking more and more about the air quality, and does, breathing in huge volumes of air, whether contaminated or not, does that affect your ability to run faster over the course of 26 miles? And this was partially part of my thoughts as over the winter. I mean, anybody who lives around here knows that Ogden is not immune to poor air quality. If you're not familiar with this area, Ogden is actually right under that blanket of smog there. This is the top of Strawberry at the Snow Basin Resort. I'm sure many of you have seen this site. It looks like a magical wonderland until you realize that that's all contaminated air that we're breathing as soon as we come off the mountain. And it's no hidden secret that there's been documented many times that poor air quality is related to increased injury, and that ER admissions for respiratory diseases increase during times of poor air quality. And the recent JAMA article actually showed that improving air quality decreases these hospital admissions and ER visits. And so we know that it can affect those with injured lungs, those with pulmonary disease, but what about the elite athlete? What about the endurance athlete who otherwise is healthy? Does it affect them? And this led me to a literature search, which almost all the articles pointed to one event, and that's the Beijing Marathon. If anybody remembers from the Olympics, there was quite a bit of controversy about making athletes run through the poor air quality, and this is not from the Olympics, but you can see that even in Beijing, there's people who are thinking about this as a possible contributing factor. Now, this picture actually also made me think about another possible study in the future, which I'm considering, and that's related to injuries with running with your phone out. So we'll see if in the future maybe I'll be able to present on that. But my hypothesis after reviewing this research, which was somewhat limited because it didn't check over, there was no longitudinal follow-up, I wanted to see if over the years, do our athletes here at the Ogden Marathon have worse performance in years where there's poor air quality compared to better air quality? And so that's the hypothesis of the study we're going to talk about here today. To measure air quality, the most common measures include the particulate matter, including the particulate matter less than 2.5 microns and the particulate matter less than 10 microns. And this kind of gives you an example of what size we're talking about. The 2.5 are the very tiny particles that can get deep in your lungs, whereas the pollen, the dust, is the particulate matter under 10 microns is oftentimes caught in our upper airways based on other studies. So the way you hear on the radio or the news about air quality is they'll take this, especially this 2.5, and they'll put it in this air quality index, and they'll tell you, oh, it's green, it's good, or no, it's moderate, or unhealthy for certain individuals. And this is how it correlates. So we're going to use that and take a look at how the PM 2.5 compares to finish times at the Ogden Marathon. And this is how we designed the study. We took all the athletes from the last several years with the Ogden Marathon and half marathon. I excluded those who were 80 and over. There just wasn't enough of them to make it adequate, though there were some finishers in that time frame. And we looked at their completion times and looked at the particulate matter during that day. We were able to control for several of the variables, including the age, the gender, of each of the participants, as well as the ambient temperature that day and the amount of precipitation, as those were all thought to be likely contributors to finish times as well. And in the end, we were able to control for those in a linear regression model. So the outcomes, we were able to get over 34,000 participants from 2010 to 2015. And the average time you can see here for the marathon, 4.5 hours, which is pretty typical. And the half marathon was just 2.5 hours. So pretty typical times. There was about 61% women, which is also a typical finding. Finish times. All right, so looking over the years, these are the average finish times. The red is the half marathon, the blue is the marathon, and they don't seem to vary that greatly, which is already a kind of an indication of where this research is headed. But there are some interesting things to find. Over the years, the average age of our participants for both the marathon and the half marathon has increased slightly. And there's a lot of thoughts for this. One, I mean, maybe more older people are interested in doing it, but also that maybe that the same group of people are just getting older, but they're still running the marathon. And it's a good thing that they are. One of the interesting findings of this was that for the most of your life, it doesn't really matter what your age is, that your completion time for the marathon doesn't really go up with age. It's only until you're getting into the later 60s and 70s that we're seeing significant changes to your finish time. So if you haven't run a marathon yet and you're interested in doing it, there's lots of people still doing it. Consider it. You can outrun a lot of the younger people and show them up. Marathon's one of those things where you can keep doing it until your older age. All right. So, and then looking just kind of some information about the environment. This was the temperature throughout the day, and this kind of also points out the nice thing that for the most of the part, we have pretty good weather during the marathon with very little precipitation, except for last year we had almost 2 inches. That was pretty impressive. 2 years ago we had quite a warm day, but other than that, it's been pretty good weather throughout. Looking at the air quality fluctuates pretty widely, with the red being the PM10 and the PM2.5 and the blue. That being said, I want to point out, and this is an important caveat to the study, if you look here, the maximum PM2.5 was 9.7, which if we go back to our regular chart here is still within the good range, showing that for the most part, we are running this marathon under good air quality, which was kind of a relieving thing for me, but will limit some of the applications of the study. And let's just move on to the linear regression model that we did. So basically, I wanted to look, controlling for the other factors we were able to measure, does the air quality alone or the temperature alone affect your finish time? And the answer is maybe, but probably not. For the first off, just looking at the marathon, these were all the significant values, and that basically indicates that for every degree Celsius increase in temperature, on average, our participants had about a half a minute lengthened to their finish time. And we're talking over the space of 4.5 hours, at 1 degree Celsius changed it by half a minute. So not a really large amount. And this isn't like sprinters where it's a second. Half a minute may or may not be that as significant. Precipitation also had an effect. But interestingly enough, being female, which I guess would possibly be expected, increased your time by about 21 minutes on the marathon and 11 minutes on the half marathon. And where temperature was significant in the marathon, it was not significant in the half marathon. And where the air quality was not significant in the marathon, it did become significant in the half marathon, meaning that for every increase in let me rephrase that. Every increase in PM2.5 per meter cubed of air increased the finish time by about half a minute. And this is just over that range of measures that we said. And the question is, well, why is that the case that in the marathon and half marathon's different? If you remember that map, a larger portion of the half marathon is run in the Ogden area, where their thought is that they have poor air quality compared to the marathon, where most of it is up in the Ogden Valley area, where there's thought to be improved air quality. And the same thing kind of goes for the temperature. So there are a few limitations to the study, because not only we only really looked at the Ogden Marathon. Every marathon is different. This is not a randomized control trial. I did not put oxygen masks on everybody and pump poor air into their lungs. That may be for the future if you can get an IRB to prove that. But temperature, precipitation, and air quality are also closely related, because as rain goes up, the temperature goes down, the air quality tends to get better. And that we're looking at kind of discrete moments, but over the course of a marathon, any runner will tell you that there's areas that are colder, there's areas that are warmer. There's lots of different ambient environments that these runners are going through, which does limit the generalizability of the study. But what we can take away from this is that over the course of our Ogden Marathon over the last few years, the temperature and the air quality have not really seemed to adversely affect our athletes, which I thought was a very relieving thing. If we were to study this on more of a larger scale, looking at more marathons, we might be able to find more of this information. And as we noticed, the air quality here in Utah tends to be worse in the winter than it is in the summer, though we can have bad days during the summer months as well. So we also briefly looked at the winter racing series, which happens in Ogden as well, and looked at their data. Running just actually kind of where we're sitting right now around Weber State University. Every year they do a 10K and a 5K. And looking at that data, I did the same comparison. Unfortunately, there's just not a lot of that data to give really definitive answers about it, but it was trending towards not being significant, that the poor air quality days when this has been run the last few years did not really seem to associate with poor outcomes for our runners. And so, in conclusion, it's been well documented that heat is related to injury, but in our study we did not see that it seriously affected finish times. Ogden Marathon luckily has pretty good weather, and it's supposed to be good weather tomorrow, so please come on out and support it. Age, interestingly enough, has minimal effects until you get to a more advanced age. I don't want to say very, I'm sorry. That has minimal effects on finish times, and that the air quality, at least over the range, the generally well-approved ranges, has little effect on our runners as well. So hopefully incorporating this more. As mentioned, I'm going to LA, so maybe I'll have to continue this down there, and we'll see how looking over poor air quality to see if that has an effect on runners there. But at least here, I can say that it does not seem to be that case. I really want to thank the Goal Foundation. They run and take care of a lot of the major events that happen in Ogden and are a great resource for our community and have been great friends for me. And also McCady, both the residency and the sports medicine department. And I thank you guys for listening to me and hope you have some good questions.
So before we turn the time over to the residents for panel questions, the first question to ask is, should they graduate? All right, we'll go with the majority opinion. Okay, questions for this group of three. Please come to the microphones. Yes, ma'am.
I have a question for Dr. Rhett Smith. So in my 9 months of practicing outside of residency, I've changed how I've done my charting. And I definitely feel for you. I wish I could sit there and have a conversation with a patient and not chart in the room. But I found that if I do that, I spend 3 hours at home at night when I should be spending time with my family doing charting. And I used to do what you did in residency as well. I would sit and talk with a patient and then take my 2 to 3 minutes to chart afterward. But now when I walk out of the room, I have 5 to 8 new messages, new medication requests. My RN wants to talk to me about an OB patient. I have a phone call from the hospital, and I simply can't do that. And so can you comment at all about the increasing frequency of documentation and how that's affecting quality of life of physicians? I mean, I think most of us would argue it's not ideal for us to be doing 3 hours of charting at night, and how do we balance that with still having that good relationship with your patient?
I think that's the golden question. If we could figure that out, it's $1 million question. I think that there are a lot of things that can help with that. Maybe if we consider more the use of scribes, that could be something that could be beneficial. And like I said, there is good data to support both the financial use of scribes, that they pay for themselves essentially, and that the documentation is actually slightly better than when the physician rushes to do it. I don't know.
The question was, is there data to support that in primary care?
I don't know if that data is specific to primary care or not. I have to go back and look at it. But yeah, unfortunately, it's very difficult in a busy practice to do what we would like to do, and I understand that. So.
Next question. Are you a doctor?
No.
Oh, okay.
So,
One of last year's graduates.
it's been
2 years ago. How quickly time flies.
so Rhett, also for you, we did not plan this, but it actually works out okay. So I've been using the iCentra for almost 1.5 years at this point, and figure I'm fairly proficient with it. I mean, I can chart in my sleep and probably have. I'm guessing here, but I would say that it takes maybe an extra 2 minutes per patient for the charting. I mean, we're talking order entry, billing, making your note, everything. And that's a guess. Maybe it's a minute, maybe it's 3 minutes, I don't know. But when I'm seeing an average of 50 people a day, that's an extra 100 minutes of charting.
Yeah.
So when do I do that? Well, I mean, again, like what Michelle said, I'm not staying 2 hours late at the end of the night, but rather what we're doing is taking 2 minutes less with the patient. So how has this translated, if you've seen anything, into perceived patient satisfaction pre-EMR implementation, post-EMR implementation? Because, maybe we're still spending good face time with the patient, but we're spending less of it with them.
Yeah.
Have you seen anything like that?
Yes, I saw several studies about both that, and I neglected to answer part of your question, which goes with it as well, which is the EHR has been correlated with physician burnout, as well as the EHR has also been correlated in some studies with decreased patient satisfaction because of decreased face time with the physician and more time with the physician spent looking at the computer.
Another semi-doctor's coming up, one of last year's graduates.
Hi, guys. So I have a really quick question. It's actually for Dawn, Rhett, so cool. You can sit back. Dawn, my question is, so I finished residency, and then I'm now in a job where I'm doing C-sections and just right out of residency. And I know you're doing a fellowship. I know Vanna is currently finishing a fellowship. I just wondered if you felt like the curriculum that you have created will help give residents more confidence in going right out of residency from McKD. Even though I think it's awesome that you're going and doing a fellowship, because I'm sure there's tons to learn, but I just wondered if you felt like it will be helpful.
That's my hope. I think that our program is changing dramatically with the evolution of the laborist program, and our training in C-sections is changing dramatically. And I think Vanna and I both did a fellowship and chose to do a fellowship for different reasons. But I do hope that our residency in 3 years can still train physicians to go out to rural places in Utah and be competent.
So one quick question for you guys. How many of you, if any, by the show of hands, have scribes? A few. All right. I hope there's many more next time we ask that question. Other questions for the panelists? A round of applause, please, then, for all of the graduates. Mark, am I turning the time back over to you? So we hope that, go ahead and come in. We'll open the luncheon, and we'll soon have our luncheon speaker up here any minute.